I wholeheartedly welcome Dr. Sahana and thank you for agreeing to take this particular class. I feel this is the most important and need of the hour for all of us. Over to you, Dr. Sahana.
Thank you, sir. Thank you, Dr. Kishan. It's always a pleasure to teach in your channel. You're doing a great job. So today, the reason why I have chosen this topic is, rightly as Dr. Kishan said, acne is like one of the most common conditions we see in our daily outpatient. And one of the most common complications or sequelae of acne is acne scars. So dealing with acne scars is an extremely tough thing. It may sound very simple, but it's actually extremely tough. So today I'll be discussing a little bit about acne. So acne is a huge topic. There are a lot of things which we do for management of acne, but I'll just be very briefly introducing what is acne, what is the cause, and how can we prevent and treat acne scars. So let's go ahead. So it's a chronic inflammatory disease of the pilosebaceous unit. So the pilosebaceous unit consists of the hair shaft, and there is a sebaceous gland which is opening to it, and a sweat gland. So all these three things together in our skin, this is called a pilosebaceous unit. So acne is one of the most common skin conditions, and it has, like Dr. Kishan already said, it very prevalent in adolescents. 90% of it starts during our teenage years, and it persists in adulthood in approximately 12 to 14% of patients. So when acne starts after the age of 25 or 30 years of age, it is called as adult onset acne. And when it starts right from our teenage years, that is in our adolescent, it's called as the normal adolescent acne. So what we have to concentrate is late onset acne or adult onset acne is almost always hormonal. It's associated with PCOD or any other underlying hormonal issues. Okay, so this is a very brief image showing what are the stages of acne and how the basic lesion is formed. So the basic lesion of acne is called a comedon. So you must have heard of the common terms which are used for a comedon is a whitehead and a blackhead. So these whiteheads and blackheads in medical terminology are called as comedons. So how is a comedon formed? So comedon, there is shedding of the skin cells and the sebum. Sebum is nothing but the oil which is produced on our face. So there is accumulation of all these things, the debris, the skin cells and the sebum inside the, if you can see the image, inside the hair shaft. So that is how the basic lesion, a comedon, is formed. And then the next stage of acne is a inflammatory papule or a pustule. So this happens when there is one bacteria which causes acne. That is not the only causative organism. Suppose somebody asks you, how is acne a bacterial infection? It's not. There is a bacteria which is implicated in the pathogenesis of acne, but it is not the only thing causing acne. There are a lot of things also. So the bacteria is called as Propionibacterium acne, or it is also called as Cutibacterium acne. So there is already comedon, and then on top of that there is bacterial infection. So that forms an inflammatory papule or a pustule. And the next stage is called a nodule. So when there is marked inflammation and there is rupture of the follicular wall and there is release of all these debris and the bacterial contents outside, so it becomes a big nodule. So these are the three lesions which are found in acne: comedons, papule or pustule, and nodule. And very severe form of acne is called a cystic acne. So the next stage from nodule, it becomes a cyst where all the contents are enclosed in a cyst. And what you have to basically remember is the 4 stages of acne is comedon, inflammatory papule or pustule, nodule, and then cyst. Okay, these are a few images. Like the image A, if you can see the small white dots, they are called as comedons, and both image A and image B are comedons. So I'll tell you what is the difference between image A and B. So A is called as whiteheads. Like in the commoner terms, figure A depicts a whitehead and figure B depicts a blackhead. So there are 2 types of comedons. So one is called an open comedon and one is a closed comedon. So what you can see in figure A, the whiteheads, they are also called as closed comedons, in the sense they are not open to the outside. And B, they are called as open comedons. Open comedons, the follicle is open to the outside atmosphere, so it gets oxidized and it is black in color. That is why it is called as open comedons. Okay, so whiteheads are closed comedons and blackheads are open comedons. And in image C, you can see the inflammatory papules and pustules. And in D, you can see the nodules and cysts. So these are the stages of acne. And this is severe acne, where you can see on the forehead very severe nodules and cysts and some hemorrhagic lesions on the chin. And severe acne, there is usually involvement of the back and the arms also. So this was like a very brief introduction to the. So now you know the basic pathogenesis of acne and the types of acne. Okay. So now we'll move on to acne scarring. So when does scarring happen and what can we do to prevent it? So acne scarring is more likely if the treatment is delayed. Like any acne, even if it is the mildest or it is the severe form, obviously requires treatment. Even the mild form, we usually treat. We don't just send the patient away because any form of acne can lead to scarring. It is more common in the severe forms like the nodules and the cystic form, but even the mild forms of acne can also cause scarring. Okay, so the prevalence of acne is 95%. Okay, so all acne patients usually develop some or the other types of scars. So I'll discuss about the types of scars on the next slide. So you'll know what are the types of scars, and 95% of acne patients develop scars, and 30% develop significant scarring. Okay. So acne scars are, they impair the quality of life, and they are a risk factor for suicide, depression, low academic performance, and unemployment. So there was a study which was recently conducted, and many people don't believe this, and it is unbelievable. The most common dermatological condition which leads to suicide among patients with skin conditions is acne. So acne causes a lot of mental turmoil and turbulence, and we may see it as, we usually dismiss it as this is just acne, why are you so worried, but it actually causes a lot of psychological impairment to the patient. So early treatment to minimize the appearance of acne scars. So acne scarring is permanent. So this is what I always tell my patients, that it's very easy to treat acne, but once you develop a scar, the scar is very, very difficult to treat. It's permanent. The appearance can, however, be improved with various medical, laser, and surgical approaches. So all this I'm going to discuss today. What are the medical things we do? What are the surgical approaches we do? And what are the lasers? So I'll discuss about this a little bit in detail, so that these are all the procedures that we offer to the patient. Okay, so very briefly about the classification of acne scars. So basically, there are two types of scars. This is common across, even in surgery to read that there are two types of scars. One is atrophic and one is hypertrophic scars. Okay, so most commonly, patients of acne develop atrophic scars. 80 to 90% develop atrophic scars. So there are three types of atrophic scars. You can see from this image. So one is called, the most common type is ice pick. So ice pick is the one in the middle. It's the V-shaped scar. And the second most common is the box scar. So box scar, if you can see the image on the extreme right, that is a box scar. It is M-shaped. And the other one is, it is U-shaped. The rolling scar is the least common. Rolling is M-shaped. So there are three types. Most common is ice pick. The other one is box scar, and the other one is rolling. So there are three types of scars. The deepest one is ice pick scar. Okay, again, here you can see ice pick is rolling scar. In rolling scar, there is something called as, can you see the three lines which is adhering it to this mass? So that is, they are all fibrotic bands which are actually pulling down the skin. So this you have to remember, because in the treatment, again, I'll be talking about this, we release the fibrotic bands which are adhering the scar to the skin. I'll tell you the methods which we do all this, but there are different treatment modalities for each type of scar. This is why you have to remember what type of a scar is present. Okay, so these are the clinical images of the different type of scar. This is the ice pick scar, like how in the diagram it was depicted as V-shaped, but it is on the surface of the skin, the patient's skin. This is how it looks like. So it's defined as a narrow, deep, sharply marginated epithelial tract that extends vertically. So this is the deepest scar, like it goes down to the deep dermis or even the subcutaneous tissue sometimes. Because the surface opening is usually wider than the deeper infundibular. So the width is more than the surface. Okay, and So this is the rolling scar. Again, it's difficult to differentiate as you see patients on a daily basis, and we keep examining with a magnifying glass or with a dermoscope. You cannot see all these type of scars. You cannot differentiate with your bare eyes. You have to have a magnifying lens or a torch to be able to differentiate. Okay, so this is a rolling scar. So rolling scar is due to dermal tethering. So this is the term which has to be remembered here. Dermal tethering, like I showed you the bands. So in this slide, you can see the 3 bands which is holding the skin to the underlying surface. That is called as dermal tethering. Okay, so this is because of abnormal fibrous anchoring of the dermis cutis, which leads to superficial shadowing. Okay, so just no need to remember it in detail. You just have to remember the 3 types of scars. This is the box scar. I mean, this is the very common. This you can appreciate in all the patients. So these are round to oval depressions, and they may be shallow or they may be deep. So just remember the 3 types of scars. So these are the 3 types of atrophic scars. Atrophic scars are the most common ones. Now we'll move on to hypertrophic scars. So hypertrophic scars are because of excessive collagen deposition. Okay, so they are typically pink and they are raised and firm, and they are within the borders of the original site. So this would have studied in surgery. What is the difference between a hypertrophic scar and a keloid? So one of the most common things which we say is hypertrophic scar, the borders are within the original site of injury, and in keloid, they extend beyond the border. So that is the typical definition of how you differentiate a hypertrophic scar from a keloid. Okay, so in contrast, like the next line is keloids form reddish purple papules that proliferate beyond the borders of the original bone. So this is how you differentiate. Okay, so just again a very brief slide just to revise. 3 types of atrophic scar and a hypertrophic scar. Okay, so there is another new type of scar called as papular scar. So let me just show the image. So these are the papular scars. They don't actually look like scars. So if you can see on the nose, you can see very little red raised lesions. So people actually mistake this for active acne, and they keep treating with all the creams which we give for acne, adapalene and clindamycin and all these things. But these are actually scars, and they don't respond to the conventional acne creams. We need to treat it as an acne scar. And even on the chin, if you can see, a lot of people have these small lesions on the chin. Even that is not a typical lesion of acne. It is a papular scar. Okay, so papular scars are 3 to 4 mm skin to flesh colored cobblestone like papules, which are distributed anywhere on the body, but most commonly on the chin, nose, and back. So they are often incorrectly diagnosed as acne, but do not respond to traditional acne treatments. Okay, so papular scars, again, you can call it like a type of hypertrophic scar, but they don't exactly come under hypertrophic as well. They are exophytic in nature and they produce a cobblestone-like appearance. So you have to remember the 3 classification of scars. One is atrophic, one is hypertrophic, and the 3rd type is papular. Atrophic has 3 types: ice pick, rolling, and box scar. And hypertrophic has the other type is keloid and papular scars. Okay. Okay. So this, this I was already telling you the impact of acne scars on the quality of life. So they have a very significant negative impact, and the need of early treatment is required to reduce the risk of scarring in all types of acne. Not only that, only the severe types of acne require treatment and they can cause scars. Even the mild, even the comedogenic acne, the milder forms of acne can also cause scarring. Okay, so this was a study which said that out of 100 patients, 36% were self-conscious of their acne, and 24% felt that their acne scars was affecting their social activities. Right, so now we'll move on to the management of acne scars. Prevention is always the first step. Prevention is always better than treatment. So we have to reduce the duration and intensity of inflammation as much as possible. So the first thing I always tell my patients is, whenever you get a new acne, just leave it. Just leave it as it is. Don't press it. Immediately, patients press it or pop it. What that will do is it will just increase the area of inflammation. If you're manipulating the acne lesion, it will just increase the area of inflammation, and for sure there will be post-inflammatory hypertrophic scarring. So if you get nobody is acne free. Acne is something especially all women they have a premenstrual flare, and most of the men also do have acne. You cannot completely prevent acne from happening at all. But what you can do is, once you get a new acne lesion, don't manipulate it. Just you can apply the creams, whatever is prescribed. We'll discuss about the treatment of acne proper in another class, but this will only be about the management of scars. But you have to decrease the duration and intensity of inflammation as much as possible. So topical retinoids, you might have heard of creams like tretinoin or adapalene. So all these are topical retinoids. These are very useful in the prevention of acne scars. Okay, so these are the pre-treatment issues. The first line is extremely important, that this is true for any procedure in dermatology, establishing realistic expectations for the patient. That acne scars cannot be completely removed, and several procedures may be required. So once the patient gets a acne scar, they will, a lot of patients come to me saying that I'm getting married in a month, I have a function in 2 weeks, I want a clean face, I want a glowing face, I want clear skin. That is not at all possible. So during the first consultation, what we usually do is make the patient understand that this is a chronic process, because in any surgical branch, like how long you take for a post-operative scar to heal and for the skin to go back to how it was before. Even acne scarring is also like that only, but patients don't usually understand that. They think that acne is something which can be solved overnight. You must have seen a lot of videos on Instagram or Facebook, where a lot of beauticians are doing all these procedures, and they're manipulating the acne. They're doing a lot of facials, and they show this pre and post. Immediately post, their whole acne is gone. Or you must have heard of some Korean technique where they apply one cream like this and they remove, and all the acne is gone. All that is it's not at all possible. So realistic expectations is important, and post-treatment rest for up to 2 weeks. This is not true in all the procedures, but there are a lot of laser treatments and radiofrequency ablations and derma rolling. I'll discuss about all this. So all those treatments usually cause a lot of redness on the face, and you cannot go out in the sun a lot. So usually up to 1 to 2 weeks after the procedure, we usually ask the patient, don't schedule any events, don't schedule any functions. Okay. So certain procedures can exacerbate acne. So those with active acne must undergo treatment, and the acne should not be active for at least 6 months to 1 year. So never do any of the procedures for the treatment of acne scar when the patient still has active acne. Any manipulation you do when you still have active acne, it will only increase the acne. So this is what I advise all my patients. All of them ask me, doctor, should I get a facial done? Should I get a bleach done in the parlor? So what they do in a facial in the beauty parlor is they massage your skin so vigorously. They scrub it. They use a lot of rough techniques, which will only increase your acne. If you have acne prone skin, most of the patients who come back to me are usually post facials, post bleach, where they I got a facial done 2-3 days back. Now my face is erupted in acne. That is extremely common. So if you are doing anything, even rubbing your skin when you have acne will increase your acne. So we don't do any treatment for acne scarring if the patient has active acne. At least 6 months to 1 year, there should not be any new lesions. Only then we do all these procedures. Okay. So pre-operative assessment, we take a detailed history, and specific history is herpes. So a lot of patients have herpes simplex, or is also called as herpes labialis, and they won't even be aware that this is something they have. So these are also called as cold sores or fever blisters, the small fluid-filled lesions which you get on the lips, on the corner of your lips whenever you have a fever. That is actually herpes. So anything which you do on the face can reactivate herpes. So patients with a history of herpes simplex, we usually give a course of acyclovir before doing any procedure. Recent isotretinoin treatment in the last 6 months. So this is again, I discussed about this when we discussed the treatment of acne as such, but isotretinoin is a oral retinoid which is used for the treatment of very severe acne. If the patient has taken isotretinoin in the last 6 months, we usually don't do any procedure, because isotretinoin makes your skin very sensitive. Keloidal tendency, again, no procedures are done. And again, the same thing, smoking, degree of sun exposure, all these normal history we have to take. And then we examine the color, whether it is a pigmented, hyperpigmented or red scar. We evaluate the number, the type, the shape, severity, what is the depth of the scar, and we stretch the skin to see if the scar disappears. So all these are the basic examination. So pre-procedure. So in any procedure in dermatology, like before a chemical peel or before any procedure, we sort of prime the skin. So what priming the skin means is we give the patient some creams to apply it every day at home for 2 weeks before they come for the procedure. So what this does is this makes the procedure more effective. So these are the things which we start the patient on: sunscreen, topical retinoid, hydroquinone is a skin lightening cream, glycolic acid is again a skin lightening cream. So we usually give a sunscreen in the morning and a topical retinoid, like retinoid in the night. 2 weeks before we start the procedure, we give these creams to the patient and tell them that you start applying this and you come back to us after 2 weeks. Okay, so these are the grades of acne scarring. You don't have to remember this. Just remember for like MCQ purposes the name. It's called as Goodman and Barron grading of acne scar, and this is mild, moderate, and severe. Just remember the name of the classification. It's called as Goodman and Barron. Okay. Again, all this is very in detail, not required much. Yeah. So this is the most important slide. Management of atrophic scars. I'll discuss about the management of hypertrophic scars is simple. That is, it has only 1 or 2 treatments. Management of atrophic scars is the more difficult one. So we have medical line of management, aesthetic treatments which we do, surgical treatments, and lasers. So these are the 4 headings. So medical line of management is retinoids, either topical retinoids or oral retinoids. I already discussed that topical retinoid is something which is used for the prevention of acne scars, and oral retinoid like isotretinoin. But the problem with isotretinoin is it's only given for severe acne. We usually don't give isotretinoin for the mild and moderate forms. This chemical peels. Chemical peels are again a very non-invasive technique. What is a chemical peel? To tell you in very simple terms, chemical peel, there are all these mild acids, that glycolic acid, salicylic acid, trichloroacetic acid, phenol. So you might get scared hearing of all these things, that they're actually applying acids on my face. So what we do is, because the term to be remembered here is controlled destruction of the epidermis, with or without the dermis. So we cause a controlled destruction of the epidermis. So we want one layer of the epidermis to exfoliate. So we can alter the concentration of the acids as such. So we have a lot of companies and a lot of chemical peels, a lot of different concentrations. They are all gel-based peels. They are not the raw acids which we get. Okay, so when these are applied on the skin over a period of time, they exfoliate the superficial layer. One layer of your skin is exfoliated. Okay. So application of a chemical agent to the skin, which causes controlled destruction of a part or the entire epidermis, with or without the dermis, leading to exfoliation and removal of superficial lesions, followed by regeneration of new epidermal and dermal tissue. So once the superficial layers of the skin are all exfoliated, you have new skin generation or new tissue formation. So chemical peels are like the most powerful weapons in the armamentarium for dermatologists. We use it for a lot of reasons, not only acne, melasma, any type of pigmentation, for skin rejuvenation, for getting that skin glow, for removing tan, so many indications of chemical peels. We will do a class of chemical peels later. So total sunblock between the peeling sessions and 4 weeks after the last session. So sun protection or photo protection is necessary for all procedures, like in between the procedures and 4 weeks after the last session. This is to prevent post-inflammatory hyperpigmentation. So the advantages of chemical peels are it is safe and non-toxic, and a lot of people think that chemical peel means one full layer of your skin is peeled off like this, like how it's not like a peel off mask. You can't see one full layer of your skin peeling off. It is only mild deformation. Like suppose you get a sunburn, you can see a little bit of peeling of your skin. So that is how it is. It's very mild deformation. So the disadvantages are penetration is not uniform. Yeah, so that is one of the things. So our skin is not the same thickness and it is not the same size everywhere. Some areas it is thin and some areas it is thick. Like suppose the under eye area is very thin and the malar area is usually thicker. So the penetration of the peel is not uniform. And what is this mandatory neutralization? So usually after suppose we apply like glycolic acid, all these peels require a neutralizer. You have to neutralize the peel. And high risk of overpeel. Some patients have very sensitive skin, and even we usually leave on glycolic acid, salicylic acid, and all for 2 to 3 minutes, not more than that. But even then, they have a lot of burning. So that is high risk of overpeel. This is some of the advantages and disadvantages. Okay, so the next, so this was you learned about chemical peels. Now we'll go on to microderma abrasion. This is again a very popular procedure which we do. So this is called MDA. So MDA. What is MDA? It's a painless superficial treatment. So I'll just show you. Yeah. So this is the image. Like there is a like a machine. We use a machine which has crystals. So they are usually aluminum crystals or we use diamond crystals. Okay. And if you can see the image, the crystals come and strike the skin and they exfoliate one layer. So it is like a suction mechanism and with the help of crystals, the skin gets exfoliated. So this is called as microderma abrasion. Derma is skin. Abrasion is like, you know, like how you get abrasions when you fall, you get an abrasion. So it's like that. Micro abrasions are created. That is called as microderma abrasion. It usually ablates the uppermost epidermal layer, the stratum corneum. So the epidermis has 5 layers, like how we all know: stratum basale, granulosum, spinosum, lucidum, and corneum. The uppermost stratum corneum is removed by this microderma abrasion. So usually aluminum oxide crystals are used and diamond tipped devices. These are the most common things used. So this is what is meant by microderma abrasion. Again, these are the side effects which are there in all the procedures: bruising, burning and stinging sensation, photosensitivity, pain. All this is very minor and it can be prevented with the use of sunscreens. And this is derma abrasion. Derma abrasion is the more invasive form of microderma abrasion. Here you do a proper removal of the entire epidermis. So this is again this is invasive. It has to be done under local anesthesia or general anesthesia. We don't do this anymore. The more commonly performed all the lunchtime procedures, very quick procedure, is microderma abrasion. Okay. And then this is again a very popular procedure. Most of you must have heard of this or seen this: microneedling. So microneedling is done with the help of a derma roller. So the instrument which you can see here, that is called a derma roller. You can see the very small sharp needles which are attached to it. Okay, so the derma roller, it consists of fine needles which is mounted on a cylinder. And this is rolled over the target areas to lightly wound the skin. So you're actually doing like how, you know, they do this acupressure and all that with the help of a roller. So this is a roller which has needles in it. This is rolled on the skin to create these small micro channels. So this induces the collagen production. Okay. So what is the procedure for derma rollers? So first, the facial skin is disinfected with betadine, and then topical anesthetic cream is applied. Like we apply some lignocaine with prilocaine combination cream for 45 to 60 minutes, and we use the derma roller 4 to 6 times in each direction. Like horizontal, we do 4 to 6 times, vertical 4 to 6 times, diagonally left 4 to 6 times, diagonally right 4 to 6 times. So there are different depths of the derma roller, different sizes which we get. So usually you can even do this at home. The 0.5 mm, all this is available online in Amazon. So 0.5 mm derma roller is very pain-free. You can actually do it at home itself. 1.5 to 2 requires local anesthesia, requires treatment from a dermatologist. as expected, the skin bleeds for a short time because you want to create micro trauma to the skin. So you have to see the pinpoint bleeding. That is the end point. Okay. Again, yeah, when you see the results, the neocollagenesis starts 5 days after wounding and it reaches its peak 12 weeks. And the complete results are visible 32 weeks from the last stage. So this is the time duration. So you have to keep counseling the patient that you will not see results immediately. It will take you 12 to 32 weeks. Okay, again, Derma Pen is again a Derma Roller, but it is automated. Like Derma Roller is a handheld device where you have to manually do it. And Derma Pen is like this automated device where we can set the depth of the needle and there is high speed, low speed mode. We just press on the button and it is automatic. Derma Pen and Derma Roller are the same. One is manual, one is automatic. Right. This again is very popular now. Microneedling with PRP. Microneedling is nothing but Derma Roller. The other name for Derma Roller is microneedling. So PRP is something which all of you have heard. I think it's got a lot of implications everywhere. PRP is being used in all the branches now. PRP is nothing but platelet-rich plasma therapy. So we use it for a lot of confusion for hair growth. You must have heard of something called vampire facial. So vampire facial is nothing. Why is it called vampire facial? Because PRP involves drawing your own blood. So what we do in PRP is we take your own blood, we centrifuge it, and in 3 layers of form, you can see the RBC, the WBC, and the platelet-rich plasma. The platelet-rich plasma is taken out and it is injected into your own hair or into your own face. That is why it's called a vampire facial. And now it's used for a lot of other things. You inject it into the joints for knee pain. People don't want to get knee replacement into the spine. If you have back pain, it's used for a lot of things. So why? Because PRP has a rich source of autologous growth factors, especially epidermal growth factor, platelet-derived growth factor, transforming growth factor, vascular endothelial growth factor. All these growth factors are rich in PRP. So again, what is happening in any scar, like that the same process is happening in acne scar. By supplying all these growth factors, you are helping the scar to heal. Okay, again, this is another procedure called MNRF. So this is microneedling with radio frequency. All these procedures are extremely common if you go to a dermatologist clinic. So here what we do is, along with there is a machine. So along with microneedling, it will release a radio frequency energy. So it's not only microneedling, it's microneedling with radio frequency. So like how I showed you a Derma Pen. So this is also the same like that, but it goes into the skin and it releases radio frequency energy and then it comes out. So this is an upgrade to the microneedling. So this was all the aesthetic management, which I told you: chemical peels, microderma abrasion, microneedling or derma roller, microneedling with PRP, and microneedling with radio frequency. Now we very quickly go to the surgical management. Surgical management, the commonest and the most easiest which we do is subcision. So this is why I told you the pathogenesis. If you remember what I told you in rolling scars, like there is dermal tethering. So there are fibrotic bands which are holding the scar to the underlying dermal. This is released for subcision. So this is a very simple procedure. We use a sharp hypodermic needle, and then it is inserted under the skin, and then we make band like this windshield wiper like motions like this, and we cut off all the fibrotic bands. And this is a very simple, very effective procedure. As soon as you cut the bands, the scar comes up. Okay, so this is called a subcision. And all these complications are there in any surgical procedure: bruising, hypertrophy, infection. So just remember the names of the surgical procedure. This is again a very important thing which we do. It's called as cross. Cross is it's a synonym. It's called as chemical reconstruction of skin scars. Cross, CROSS. So here what we do is, this is mainly used for ice pick scars. Like if you remember, I told you ice pick scars are like V-shaped. So we take a toothpick. The sharp end of the toothpick goes and sits inside the ice pick scar. First, we dip the toothpick in high concentration of trichloroacetic acid, TCA, like 100% TCA. If you want to understand TCA is the one, if you have seen the movie, what is that, the Deepika Padukone's movie, Chapak, like, you know, where she gets a burn, that was because of TCA. All these accidents which you read in the paper, people threw acid on the, you know, the girl's face, all that is all TCA. So TCA is highly strong, 100% TCA. We just use, like, we dip a toothpick in it and we keep it inside the scar. That is the quantity which we use. It is less than 0.01 ml. So immediately you can see like a whitish frosting, and it requires 3 to 4 treatments. In every treatment, the ice pick scar comes a little above. Like, it is extremely deep. If, like I told you, the ice pick scar, every time if we do this TCA, it comes a little bit up until it is completely flat. So again, this has to be done every monthly. It cannot be done less than that. So remember, what is cross, what is the acid used. This is again the punch technique. I'll just show you the images. There is something called as punch excision, where we use biopsy punches to take out skin lesions. So there are very small punches which we can use for an acne scar. If the scar is very deep, we punch it out, and then we have to again suture it. All this has to be done by an experienced dermatosurgeon, because if you are punching out a scar, there is always a risk after suturing that you will leave the patient with a bigger scar. So all this has to be done by a very experienced surgeon. There are 3 types. One is called punch excision, and one is called punch replacement grafting. So we take out in punch excision, we take out the scar, we just suture it up. In punch replacement, we take out the scar, we take another graft from the post-auricular area, we put it back in. And one is punch elevation. Punch elevation is very simple. We take out the scar, we just lift up the scar, place it a little above, and we glue it. We put steri strip or we put cyanoacrylate glue. These are the 3 punch techniques. There is punch excision, punch replacement, and punch elevation. Okay. Dermal grafting, don't have to. This is extremely advanced. The other one is fillers. So fillers, you must have heard of Botox and fillers. So usually Botox and fillers are done for like under eye area. You must have heard of lip filler, gluteal area filler, breast filler. All these are fillers. So fillers are nothing but hyaluronic acid, all these calcium hydroxide, they're all synthetic fillers which are used to fill a particular area that there is loss of subcutaneous tissue. It can also be used for acne scars. Again, this is not required. Threads are again very advanced. All these aesthetic procedures are done for anti-aging purposes. Like threads are something, like suppose somebody has a lot of sagging skin. As we age, all our subcutaneous tissue, there is loss of subcutaneous tissue and collagen, and our skin starts sagging. So if you can, we lift up the skin like this. We put a thread inside and we pull the skin. So these are all called PDO threads. We put this is the insertion point. Put threads like this and we pull it up so that there is a lifting effect. And then we do jaw recontouring, and then we do a neck lift. So these are all aesthetic procedures, Botox, fillers, threads, but all these can also be used for the treatment of acne scars. Right, these are all the surgical techniques. So we finished discussing the aesthetic techniques. The surgical techniques are cross and punch techniques, and the ones we will do Botox, fillers, and threads. Now we'll go to the last one, is the laser. So laser resurfacing is the one which is most commonly used. There are 2 types of lasers. One is called traditional and one is called fractional. So let me just tell you what is the difference between traditional and fractional. So traditional laser, the entire skin gets destroyed. So laser, again, what it does, the principle is the same in all the things. In Derma Roller, the principle is the same. The laser, the principle is same. You perform a controlled destruction of the epidermis and you stimulate the collagen production from beneath. That is the same principle. So what a traditional laser does is it destroys the entire skin. It doesn't differentiate that this area has a scar, this area is normal, this area has a scar. It just destroys the entire skin. What fractional does is, it is it identifies where there is scarring. There is something called as microthermal zone creation. So it doesn't destroy the entire skin. Only wherever there is scarring, that is where it destroys. I'll just explain it to you. So there are two types of lasers what we commonly use. CO2 laser. So you have to remember the wavelength of the laser and the chromophore. Chromophore is nothing but the molecule which it targets. There are different chromophores. Like suppose there is one more laser called Nd:YAG laser, which we do for melasma and for pigmentation. There the chromophore is different. The chromophore there is melanin, and here for acne scars the chromophore is water. And CO2 laser, the wavelength is 10,600 nanometer. These are the two things you have to remember. For carbon dioxide laser, the wavelength is 10,600 and the chromophore is water. Then RBM-YAG laser, the wavelength is 2940. Just remember these two wavelengths, 10,600 for carbon dioxide and 2940 for the RBM-YAG. So this is ER is erbium-YAG laser. Again, not required. Not required. This is like I told you, fractional laser. This is the most important diagram. You can just understand everything from this diagram. So the first one, the figure A, shows ablative resurfacing. Again, traditional and fractional. Traditional has two types, ablative and non-ablative. Ablative, if you can see, the entire epidermis is getting destroyed. In non-ablative, what is happening? The epidermis is retained. The laser rays, they are directly penetrating into the dermis without destroying the epidermis. So which do you think is better? Obviously non-ablative, because if the entire epidermis is destroyed, you have higher chance of complications, like further chance of scarring and post-inflammatory hyperpigmentation, all these things. But in figure B, like the epidermis is maintained, only the dermis where the actual collagen is there is getting stimulated. So that is non-ablative laser. Those are much better. And fractional, that I already told you, that the entire surface it doesn't target, only it identifies and particular beams. Okay. These are all the newer and experimental treatments, again used in the premier centers, pico laser and radio frequency subcision, and there is something called a stick cell, which is not needed. Just remember medical management, aesthetic management, surgical management, lasers. In lasers, there is something called as traditional and fractional. Fractional, again, ablative and non-ablative. The two lasers that I use are carbon dioxide and erbium-YAG. Carbon dioxide, the wavelength is 10,600. Erbium-YAG, the wavelength is 2940. And the chromophore is water. This is all you have to remember. This is a overall chart which shows what are the various methods. I've discussed all these methods again now in detail. So just very briefly, we'll just revise. The medical treatment was retinoids, either a topical retinoid or an oral retinoid like isotretinoin. The aesthetic treatment was chemical P. It was microderma ablation. It was derma roller. Then it was microneedling with PRP and microneedling with radiofrequency. The surgical techniques were subcision, crosses, chemical reconstruction of acne scars. The acid used here is 100% TCA, trichloroacetic acid. The other methods are punch methods. In punch methods, you had three. One is punch excision, punch replacement, and punch elevation. And what was the other one? The other one was dermal grafting. So these are the surgical techniques. And coming to laser, again, traditional, fractional, ablative, non-ablative. These are the various modalities which are available for the treatment of acne scars. And usually the combination of this is what is required. Suppose a patient has both ice pick and rolling scar. So what I do is, first I do one session of cross, I put TCA, 100% TCA. After 2 weeks, then I do a derma roller. Multiple sessions are required of all, combination of all these treatments and multiple sessions, along with the priming agents which I told you in the very beginning, sunscreen, glycolic acid, hydroquinone, retinoids. The patient has to continuously apply a lot of things and come in for the procedure. So it is a very complicated thing to treat. The conclusion is appropriate patient selection and good understanding, realistic expectations are important to achieve a optimal therapeutic outcome, and use of combination therapies in a single or multiple session. So like in a single session also we can do two things, like we can do a chemical peel and we can do a derma roller in the same session, like after 10 to 15 minutes. Okay, so I hope you got a brief idea about, the first point is that acne scars are very difficult to treat, and I hope that you got a brief idea about what all available. There is a huge variety of things which are available for the treatment of acne scars. So I hope you understood a little bit about it. If you have any doubts, you can always leave them in the comment section and I'll try to answer them. Thank you.